Today we are going to talk about pneumothorax further. In previous lecture we talked about what is the definition of pneumothorax. As we discussed, it is presence of air or other gases in the pleura. Then we talked about what are the causes of pneumothorax. And there previously, in the previous video, we discussed about spontaneous pneumothorax, primary spontaneous pneumothorax and secondary spontaneous pneumothorax. Today, first of all, we will focus on the traumatic pneumothorax, and then we will go to the types of pneumothorax with special mention to tension pneumothorax. Very good. So first of all, we talk about traumatic pneumothorax. Traumatic pneumothorax is, of course, those kind of pneumothorax which are produced due to some kind of trauma, right, to the pleura and leading to the escape of the air either from lungs to the pleural cavity or trauma to the chest wall and then escape entry of air from outside to the pleural cavity, right? Basically, traumatic pneumothorax is divided into two categories. One is non-iatrogenic. Non-iatrogenic, and other type is iatrogenic causes. What is the meaning of iatrogenic? Yes. Iatrogenic, have you heard of it? Or iatrogenic?
Any defect which occurs during surgical procedure.
Okay, he says any defect which occurs during surgical procedure. It's not completely right. Anyone else?
Medical
yes.
Medical issues.
Due to any medical intervention, whether surgical or medical.
Okay, for example, if we do the medical interaction or surgical interaction and remove a gallbladder of a person, right? Do you think it's iatrogenic gallbladder removal? No. The most important thing which you have to understand when we say that there is iatrogenic cause, right? This is inadvertent. Doctor was not planning for this thing. This is inadvertent, right? Problem created by the medical personnel, healthcare personnel, right? And it may be surgical or medical or pharmacological. For example, you give a person drug to reduce the headache, but if that produces rashes, production of the rashes was not the purpose. It was an inadvertent, unwanted effect. We really not planned for it. In the same way, doctors do certain procedures, right, and they may end up into damage to the pleura and there is pneumothorax, right? Then we will call it iatrogenic pneumothorax, right? For example, if you do pleural biopsy, but when you do the pleural biopsy, somehow you injure the lung and then air escape into pleura. Now, you were doing purposely pleural biopsy, but you were not planning to create the pneumothorax, but inadvertently it is created. So what I want to say, that those problems which occur in the patient due to medical health personnel, or you can say problems in the hospital or due to drugs which are inadvertently, right, we say they are iatrogenic, right? So trauma to the respiratory system or chest and the lungs which may lead to pneumothorax, and that is related due to medical causes, we'll call it iatrogenic, right? And sometimes there is trauma, but it is not caused by any health personnel, healthcare provider, right? Then we say traumatic pneumothorax is there, but it is not iatrogenic. Classical example of this is simply blunt trauma. Blunt trauma. Even blunt trauma to the chest, even sometimes non-penetrating injury to the chest can lead to pneumothorax. What could be the most common mechanism? Someone, let's suppose, gets an accident, his chest hits, suppose a part of a motor vehicle, and after that person develops pneumothorax, but apparently chest does not have any penetrating injury. What could be the mechanism? Very good. One of the probability and most common probability in this situation is fractured rib. When ribs due to blunt trauma get fractured, then a pointed edge of the fractured rib may puncture the lungs, and that may precipitate pneumothorax. Is that right? Again, I will repeat, blunt trauma, which is even if it is non-penetrating, it may end up with the pneumothorax. What could be the mechanism? There can be many mechanisms, but most common mechanism is that if there is fracture of the rib and one sharp edge of the rib is bent inward and it punctures the lung, the air from the lung can escape into pleural cavity, right? Then we can talk about more simpler causes like stab wound, right? Stab wound, someone sticks a knife there, right? Of course, that is very easy to understand. There is penetrating wound and air may be entering. In that case, if someone stabs, or there is bullet wound, bullet injury, right? Now, in blunt trauma, which is non-penetrating, I told one of the mechanism is your rib may fractured or broken rib may puncture the lung. Now, in stab wound or in case of bullet injury, do you think air will be coming from to the pleural cavity from the atmosphere from outside, or it will be coming from the lungs?
From the lungs in blunt trauma.
Okay, you think that in the blunt trauma, of course, it is coming from the lungs. I'm talking about stab injury and bullet.
From the outside.
From outside. Actually, it can come from both sides. Look, if there's some bullet and that bullet produces a perforation here, and then it enters into lung and perforates that too, air can be sucked into pleural cavity from the atmosphere directly through the chest wall, and can also be sucked into pleural cavity from the ruptured lung. You are understanding? So what really happens, that let's suppose here is your lung, and here is your pleura, visceral pleura, and now this is parietal pleura, and here is your chest wall, diaphragm and muscles. Now, of course, when there is a stab injury or bullet injury, what will happen? That if this is a track by the bullet, naturally air from the wound, chest wound can also enter, and if there is damage to the lung, from the lung and also air can escape and enter. So there can be double route of entry of air. Is that right? Yes. So we have talked about traumatic pneumothorax. Trauma is there, and non-iatrogenic. Some people call it iatrogenic, some people call it iatrogenic, some people simply call it iatrogenic. Whatever you want to say, right? But your concept should be clear. So these are three most important causes where trauma to the lungs can produce pneumothorax, right? Then we come to iatrogenic causes. This is very important. These are induced by the medical care system. What could be the causes? Iatrogenic. At the top, I would love to write, no, CPR. Sometimes when we are doing very aggressive CPR, sometimes ribs can rupture, and those broken edges of the rib again may puncture the lungs and produce pneumothorax. Right? Then any other cause you can tell me? Okay, very good. He tell pleural biopsy. Very right. I just mentioned pleural biopsy. Yes. Any other cause? Don't forget to tell me. Yes. Ventilation. Artificial ventilation. Mechanical ventilation. Positive pressure mechanical ventilation. What kind of mechanical ventilation? Positive pressure mechanical ventilation. It can produce barotrauma, and that barotrauma can rupture some alveoli and produce pneumothorax. In positive pressure, you are pushing the air, right, through the ventilator under pressure to the lungs, and sometimes some part of the lungs or alveoli may rupture and end up into production of pneumothorax. So these two are, of course, iatrogenic causes. Then pleural biopsy, right? So what we are talking about, that either you injure the ribs through blunt trauma or injure the ribs during the CPR process, right? What does CPR stand for? I know you know it. Cardiopulmonary resuscitation. Or from outside, there is positive pressure, mechanical ventilation, which may produce barotrauma and lead to the air leakage. And then we talk about biopsy. Yes. Pleural biopsy is from outside. If you take, and unfortunately if there's damage, rupture, damage to this tract or to the lungs, that may precipitate pneumothorax. And then transbronchial biopsy procedure, right? When, for example, in case of some diseases of the lungs, we want to take a parenchymal tissue as a sample from the lung. When we are passing that instrument, which will eventually instrument will reach through the airways, right? But then it will penetrate and take a tissue from the lung while going through the wall of the bronchial system. So we call it transbronchial biopsy. But it may produce puncture of pleura sometimes, right? Or puncture of lung parenchymal tissue damage. The pleural biopsy, and then another procedure you should not forget, thoracentesis. What is thoracentesis? We make a hole where? We make a hole in the thorax, then thoracentesis. Someone will tell me with a better explanation what is thoracentesis. Thoracentesis is basically a procedure by which we drain the intrapleural fluid, where we remove intrapleural fluid for therapeutic purposes or for diagnostic purposes. Sometimes there is pleural effusion, right? And we pass a needle and we want to remove some fluid from the pleural cavity, and that fluid may be sent to the laboratory, right? Then we say it is diagnostic thoracentesis. Or the fluid there needs to be drained if there's massive what? Pleural effusion. And we need to remove the fluid from the pleural cavity to reduce the pressure on the lungs, to improve the ventilation. So that is thoracentesis. So how many causes you know? If you forget everything, please don't forget these two causes. Iatrogenic, right? CPR and positive pressure ventilation, then transbronchial biopsy, pleural biopsy, thoracentesis, and then very special cause, that is central venous catheterization. Central venous catheterization. I will go into detail of that. Yes, you have a question?
Sir, that thoracentesis and pleural tap, all these same things?
Yes. Thoracentesis and pleural tap, they are one and the same thing, right? Okay. Now, central venous catheterization, right? That may sometimes damage the respiratory system in such a way that pneumothorax may occur. CVC. What is CVC? Who has the concept of? Have you heard of central venous line or CVC, central venous catheterization? Anyone who has heard of it? Yes. Have you heard of it? CVC? Anyone? I'm teaching pneumothorax, not CVC, but I think I need to tell a few words at least. CVC is central venous catheterization, actually. This is a procedure in which we put a catheter in a vein. It may be which vein? Internal jugular vein, or subclavian vein, or axillary vein, or even sometimes femoral vein. We put a catheter there, and that catheter passes through, for example here, passes through the internal jugular vein, and then eventually it reaches to, yes, vena cava in the thorax. Or even we can push it up to the right heart. So whenever, through any major vein, you push a catheter which reaches thoracic portion of vena cava, or even reach to the right atrium, then we say what we have placed, central venous catheter. Most commonly we talk about that we pass it through internal jugular vein or subclavian vein, and sometimes axillary vein, and less commonly even through the femoral vein, right? But remember, if we put from internal jugular vein, it is central venous catheterization. But if you let's suppose pass through femoral vein and take it up to the thoracic part of the portion of the cava, vena cava, will it be central or not central? If it is from femoral vein, it will be still central. The real understanding is that when we say there is central venous catheterization, right, important thing is that catheter end should be in the thoracic portion of vena cava, or even pushed up to the right atrium, right? We say we have put a central line. It doesn't matter, it will be still central line because it is present in the center. It may be internal, initially we accessed that area through internal jugular or through subclavian or through axillary or through femoral, right? Now, important thing, sometimes when you are doing this procedure, you are establishing a central line or central venous line or central venous catheterization. You may damage the lung tissue or you may damage the pleura, and that may end up into pneumothorax, right? So how many causes of, you can say, iatrogenic causes of traumatic pneumothorax, because this is also traumatic and this is also traumatic. The difference is this is usually inadvertently done by the healthcare providers, right? And CPR, positive pressure, mechanical ventilation, transbronchial biopsy or pleural biopsy or thoracentesis, and of course you should not forget, what is this? Central venous catheterization. Any question up to this? Okay, now we move ahead. We have already discussed up to now that what are the causes of pneumothorax, right? Some causes were discussed in previous video, some are discussed now. In previous video, what causes we were talking about? Primary spontaneous pneumothorax, which we talked about, that this is usually seen in tall, thin, young males, and smoking increases the risk, where a subpleural bleb or bulla ruptures and produces a pneumothorax, right? Then we were talking about spontaneous pneumothorax, but secondary, in which I said there is some underlying pulmonary disease, lung disease, which predisposes the person to develop pneumothorax. We talked about there may be COPD, like emphysema, patient with emphysema or patient with chronic bronchitis. These two are COPD, or other obstructive diseases like asthma or bronchiectasis, or even we talked about some cavitatory lesions in the previous lecture. There are some cavitatory lesions and destructive lesion in the lung, like lung abscess, severe pneumonia, or yes,
consolidation case of TB,
tuberculosis, cavitatory lesions, even squamous cell carcinoma can undergo cavitatory phenomenon. Then today we talked about that pneumothorax not only occurs spontaneously, it can occur due to trauma also, because previously we defined that spontaneous pneumothorax is a condition in which pneumothorax is there but there is no antecedent warning or trauma. Is that right? But then those cases where clear cut there is trauma to the pleura, right? And air has escaped into or trauma to the chest wall. In this cases, non-iatrogenic and iatrogenic, right? Now we come to that what are the mechanism wise, what are the types of pneumothorax? Up to now we talked about types of pneumothorax according to the etiological, right? So etiologically we discussed that there can be spontaneous pneumothorax and there can be traumatic pneumothorax, and spontaneous primary can be there and spontaneous secondary can be there, and traumatic pneumothorax can be non-iatrogenic and iatrogenic. Is that right? But then once pneumothorax establishes, after that, how the pleural air in the pleura and the entry point from where the air is entering into pleural cavity, how that point behaves, This is very important. The point through which what is happening? Air is entering into pleura. How that entry point behaves during respiratory cycle. That also subclassifies what? Pneumothorax. Let me explain what are those, right? Actually, there are 3 types of pneumothorax according to the types. There is closed pneumothorax, there is open pneumothorax, and then there is tension pneumothorax, right? So we'll talk about types of pneumothorax depending upon the underlying mechanism, right? Now we'll talk about the types of pneumothorax. First of all, I will talk about the closed pneumothorax. Closed pneumo. Then we'll talk about open pneumothorax. And then we'll talk about, yes, tension pneumothorax. Now, closed pneumothorax. What is your, what really you have any concept? What is closed and open pneumothorax? Anyone who has a concept? Yes. I think you people don't like pneumothorax, am I right? Yes. Have you heard of these terms? Closed pneumothorax, open pneumothorax, and tension pneumothorax. Yes.
I think in closed pneumothorax, the fluid cavity is intact. There is no rupture of fluid cavity.
Okay, let me tell you before you tell me so many new things. Today you are hot. So, let's suppose here is your lung, right? Here is your which pleura? Visceral pleura, which is in intimate relationship with the, and this is visceral pleura, right? Now, let me explain the closed pneumothorax. Here we put, yes, some ribs, right? Intercostal muscles, diaphragm. Now, listen carefully. Let's suppose in this person, point of entry was here. There was bleb here. You remember that in previous lecture I told you there can be pleural or subpleural bleb. There is air-filled space. Let's suppose this bleb ruptures. When this ruptures, air will enter into pleural cavity. This air has entered into pleural cavity. But once the air has escaped, after that, spontaneously, this point through which air has entered, that closes. Or I will give you another example. Let's suppose there was some injury here, right? And air from outside entered here, right? Now, this is the, what is this? Opening through which air is going. Let's suppose this is the opening due to trauma where air is going, right? Now, after the injury, for example, someone put a knife and knife is pulled out, then if this point seals automatically, it seals automatically, spontaneously, then what will happen? Whatever air has entered, it will not escape, but no further air will also come. Such cases where the point of entry of the air, either from the visceral pleura or from the parietal pleura, once air escape into pleural cavity, after that the point of entry automatically closes. Then we say this is pneumothorax, but it is closed pneumothorax. What is it? Closed pneumothorax, right? So what is closed pneumothorax? If I'm going to have pneumothorax, I will wish I should get closed, not the other types. Most commonly, closed pneumothorax, classical example is primary spontaneous pneumothorax, where a bleb ruptures, air enters into pleural cavity, then automatically that visceral pleura point seals off, or that closes off. Now here, the air will be trapped here, but it is not going out, right? It is not going out through the point from where it came, right? And no more air is coming. So air is trapped within the pleural cavity, some amount of air. In this case, this is, again repeat, what type? Closed pneumothorax. In closed pneumothorax, if it is not very large, if it is a small closed pneumothorax, usually air gradually absorbed through the pleural walls, and over time pneumothorax disappears. Lungs again re-expands. Again listen, closed pneumothorax. In closed pneumothorax, what happens, once the air has entered into pleural cavity, after that the point of air entry closes spontaneously, right? So no more air is entering through that point, and air is not even escaping from that point. So in a way, air is into a closed system, but air will gradually absorb through this. Sometimes then usually we just, if it is not a very large amount of air, small amount of air, we just wait and see, and it will be absorbed. Sometimes to enhance the rate of absorption, we give the person oxygen. To increase the rate of absorption in some pneumothorax, we give oxygen. What do you think? How oxygen will help, high concentration of oxygen will help the air to be absorbed? First of all, tell me, yes.
Hyper respiration.
Anyone else? I'm saying in pneumothorax patients, one of the treatment modality is you give oxygen. How the oxygen can help in relatively faster absorption here from air from here and the expansion of lung.
Concentration of oxygen is higher.
Okay, when you give oxygen, concentration of oxygen will eventually here also will become higher. It may be closed or even, right? Now, how that will help to absorb? Listen, before you tell me totally new way. Actually what happened, when we say air is trapped, air is 79% nitrogen, almost. Nitrogen is slow absorber. It does not absorb very rapidly, right? Oxygen absorbs far more rapid way as compared to nitrogen. When we are giving the person oxygen, gradually here, oxygen concentration increases and nitrogen concentration drop. And whatever trapping is there, that will go under absorption process fast. Is that right? So again I will repeat that one of the treatment in case of stable cases of pneumothorax, that we give high concentration of oxygen, especially in those cases where from lungs diseases air has escaped into pleura. It means that is secondary spontaneous pneumothorax, right? So is that clear? Yes.
Sir, in closed pneumothorax, no new air is being entered into the pleural cavity. So how the concentration of oxygen rises in that cavity?
The thing is that no new air is escaping here through the entry point. But actually walls of the pleura, right, they do have some exchange. As we say, if air is left here, from here it can absorb. And if high concentration of air is here, actually what is happening? Some air is being absorbed and some is still escaping. Once this is separated, by giving a lot of oxygen, we are raising the concentration of oxygen here, right? This is possible in primary pneumothorax spontaneous, and it can be spontaneous secondary pneumothorax. Is that right? The purpose of role of oxygen is that you increase the concentration of oxygen here and decrease the partial pressure of nitrogen, right? That will end up into faster absorption because nitrogen is slowly absorbed and oxygen is more rapidly reabsorbed. I must use the word, right? Secondly, in this case, when it closes, okay, this was the flap and this flap closes here. What will be the pressure in the pleura? Negative or positive or equal to the atmosphere? And it will be, my question is, once a patient comes to you, patient is already having pneumothorax, but this is closed pneumothorax. What is it? Closed pneumothorax. With the time, the pressure here will be equal to atmospheric pressure, or it will be more than atmospheric pressure, or pressure here will be less than atmospheric pressure. Answer intelligently.
So pressure will gradually drop because...
Very good. As in case of closed pneumothorax, and more air is being absorbed and new entry is less, then pressure here will remain subatmospheric pressure, right? It is negative pressure. Is that right? Normally in the pleura, there is negative pressure during normal breathing. During inspiration, negative pressure become more negative, and during expiration, negative pressure become less negative. For example, in normal breathing, when I'm pulling the air in, negative pressure in intrapleural pressure may be -5. But when I do expiration, right, it will become -3 in the pleural cavity. Is that right? So during normal breathing cycle, throughout the inspiratory and expiratory cycle, throughout the respiratory cycle, pressure into pleural remains negative. Is that right? And in this case also, because that entry point has been sealed, and after that whatever air is here, that is being absorbed, right? So progressively it will re-establish its negative pressure. Is that right? Now we come to open pneumothorax. What is open pneumothorax? Now open pneumothorax. In open pneumothorax, what happens? That the point from where the air is entering, let's suppose this is the point, right? This point may be from chest wall, or there may be damage to the part of a lung and air has entered from here, either from here or from here, right? If enters here, air enters into pleural cavity, it loses its what? Negative pressure, and air is trapped over here, we say there's pneumothorax. But if this entry point during inspiration and expiration is not closed, rather behave as a two-way tunnel for the air, what will happen? That during inspiration air will go in, and during expiration some part of the air will come out. Then during inspiration air will go in, during expiration air will come out. This type of pneumothorax, where the point through which the air enters into pleura, this point remain open throughout the respiratory cycle. That this point remains open during inspiration as well as during expiration. Here air in the pleura will be equilibrating with the air either in the outside the chest wall or equilibrating its pressure with the air present in the airways in the lungs, right? This is called open pneumothorax. This is a two-way pneumothorax, right? We call it open pneumothorax. Let me write, in closed pneumothorax we call it, I can say it's what is no-way pneumothorax. What is it? Once the air has entered, then there is no way to rapidly escape. No-way pneumothorax. But this is two-way pneumothorax. Two-way entry point. Okay. Now, in this case, the air in the pleura pressure, the pressure, intrapleural pressure will be equal to the atmospheric pressure. Here it will be always, from the beginning, with little absorption, pressure in case of closed will be subatmospheric. Intrapleural pressure will be subatmospheric. Here intrapleural pressure will be equal to atmospheric pressure. It will be, intrapleural pressure will be, intrapleural pressure will be equal to atmospheric pressure. Is that right? We call it open pneumothorax. Here I want to mention one thing. In case of closed pneumothorax, chances of development infection in pleural cavity is less. But in case of open two-way pneumothorax, chances of developing the infection is more. Right? So now you know the difference between open and closed pneumothorax. If entry point releases the air into pleural cavity and spontaneously closes, what kind of pneumothorax is there? Closed pneumothorax. But if entry point remains open throughout the respiratory cycles, and during inspiration air comes in, and during expiration it escapes out. Always some air is sucked in, and during expiration somewhere is escaping out. In this case we'll say two-way passages there. We call it what kind of pneumothorax? Open pneumothorax. Is that right? Now we come to the most dangerous complication of pneumothorax. That is the tension pneumothorax. Why we call it tension pneumothorax? Because when doctor sees such patient, doctor develops tension or what?
No,
Doctor does not develop tension. Okay. Nurse develop tension. Why we call it tension pneumothorax?
patient is in stress.
Patient is in stress. Rather, I must say patient is in distress.
Distress. Doctor. So sometimes.
And doctor should also become distressed to manage this. Remember one thing. Tension pneumothorax is a type of pneumothorax in which air in the pleura is under tension. Trapped air is under tension, under high pressure. And if you suspect, now I will ask a question to one person. If you suspect that there is a person, the patient has come to you and patient has a history of sudden chest pain, and after that patient developed dyspnea, right? And when you examine the chest, you suspect, I will tell you what are the findings in chest later, you suspect that there is tension pneumothorax. My question is, with this young man, that which investigation you will order first of all? Yes, please. Pneumothorax can be detected on chest X-ray, can be detected by ultrasound, and with very big detail, it can be detected by CT scan. My question is, I really want to hammer this in your mind, this question, and its right answer, that if a person comes with chest pain and severe dyspnea, and you have some findings in the chest, which I will tell you later, and you suspect that there is tension pneumothorax, you should immediately refer the patient for X-ray, chest X-ray, or ultrasound, or CT scan, or what should you do? CT scan. Remember, you may receive the dead body back.
This is very emergency condition.
It's a very emergency condition. This is what I want to hammer in your mind, right? In your cerebral cortex, even into your cerebral cortex. That once you suspect tension pneumothorax, I have not explained what exactly it is, but I'm telling you, once you suspect what? Tension pneumothorax, you should be under tension. You should not send the patient for any investigation. Every minute counts. The immediate step which a good doctor or a healthcare provider will do, that is decompress the chest. Immediately. Immediately find some wide bore needle and push it through second intercostal space in mid-clavicular line on the suspected side of pneumothorax. Stick the needle, and if lot of air come out, diagnosis is confirmed. And it's not only about diagnosis. When air will come out, pressure on the lungs will be reduced. And that may be life-saving. I will explain. Because if tension pneumothorax is not rapidly managed, it will end up into ventilatory failure, severe hypoxemia, and also cardiovascular collapse. I will tell you the mechanism. But first you remember one thing, that when we say there is tension pneumothorax, healthcare provider, as soon as he suspects there is tension pneumothorax, healthcare provider should be himself or herself under tension. Right? Not sending the patient for any investigations. Because it will waste very, very important time. You are understanding? Next time in your life, it means you should know how to clinically diagnose tension pneumothorax. To make a diagnosis of tension pneumothorax, you are not supposed to depend on the labs, investigation. A very good doctor, even very good nurse, rather every nurse and every doctor, every medical health care provider should be able to suspect and make a reasonable suspicion of tension pneumothorax. Is that right? Now what's wrong in the tension pneumothorax? I told you in closed pneumothorax, once the air has escaped here, it is no way. Right? The point through which the air escaped, that has been closed. In open pneumothorax, there was two-way air passage. Right? That air will enter into pleural cavity during inspiration and escape during expiration. Do you think here, because air has an escape way, Whatever enters, some of it also escape. So here the air is not developing tension. Let me tell you how the air may develop tension in the chest. Look here. This is your beautiful heart, right? And here is your cable system. Superior vena cava coming from here and inferior vena coming from here. Now you imagine what has happened here. It's a very bad situation, very, very bad looking. Okay, let me draw it again more clearly. What happens in tension pneumothorax? First of all, I must draw the right heart. This is the left heart, right? This is suppose normal first of all. I'm making the normal lungs. And of course here is the pleural. What is this? Visceral pleura and parietal pleura, and same here. Visceral and parietal pleura. Right? Here is of course your respiratory passage is also coming and going to both sides. Now, and here is your chest wall. Let's suppose I make it chest wall. Now please focus on this diagram. What really happens? Let's suppose there is stab wound here. There is stab wound here. Okay, I'll make it more oblique. Right? And this is the point of entry. Now, just imagine that once, let me correct it a little bit. Let's suppose air is coming from chest wall, right? This is your which pleura? Visceral. And what is this pleura? Parietal. Now you imagine this is the entry point. When person is doing inspiration, from here the air is sucked in. From the entry point during inspiration, air goes in, right? It is entering in during inspiration. But during expiration, this flap is compressed against the other part. When this is compressed again, air cannot escape. During inspiration, air enters. But during expiration, this flap seals the exit point.
One-way valve.
So it converts into one-way valve. It's not two-way anymore. With every inspiration, it will take the air in. With every inspiration, a little air will come in. But during expiration, it automatically seals and air cannot go out. So what happens? With every respiratory cycle, air will progressively enter into this. When air will enter, it will lead to collapse of the lung. It will lead to collapse of the lung. And with the time, there may be so much air that, first of all, now what is happening? With every inspiration, air is coming in. During expiration, it cannot go out. Within inspiration, more air come in. During expiration, this closes and it cannot go out. So in a way, pleural cavity convert into an air trapper. It sucks the air in but does not release it out. So with the time, pressure here will become more and more positive. And when more and more intrapleural pressure will become positive, this will push the lungs. Of course, normally when air enter here, both layers of the pleura are separated, and due to lungs natural recoil, lungs become collapsed. But in this case, story is more than that. Not only due to their natural recoil, lungs become collapsed, but because air is progressively accumulating into pleural cavity and developing very positive pressure. Really speaking, air in pleural cavity is under tension. Of course, if you enter somewhere and you are not allowed to escape, what do you think? You will be under tension or you will be happy? You will be under tension. You enter somewhere and you are not allowed to exit. You will be under tension. Same thing happens when more and more air during every inspiration come out but cannot go out. Come in and cannot go out. Remember, this air can come from lung side through visceral puncture, visceral pleural puncture, or may come from parietal. But once such a valve mechanism develops at the point of entry, that with inspiration air comes in, during expiration flap closes. This is one way. This is one-way valve. Here, progressive accumulation of air into pleural cavity, there is a big pneumothorax and it is under high pressure. So it will push the structure with pressure. Not only affected side of the lung, even that lung is pushed on the other side. Even that pressure may compress and may lead to compression of cable system, even kinking of the cable system. You mean that due to all this thing, distortion will develop here. And what could be the distortion? That superior vena cava may become like this, inferior vena cava come like this, and this was the lung here which is under pressure. You are understanding? I must say it is something like this, very dangerous situation. This is called tension pneumothorax. What is tension pneumothorax? Tension pneumothorax is a type of pneumothorax in which intrapleural pressure remains positive throughout the respiratory cycle. During inspiration or expiration, pressure here is positive. Why tension pneumothorax develop? It occurs in those situations where the point of entry of air into pleural cavity act as one-way valve. During inspiration, air escapes, but during expiration it cannot exit. During inspiration, air enters into pleural cavity. During expiration, it cannot go out. Due to this reason, there is progressive accumulation of air. And this air develops pressure more above the atmospheric pressure. Is that right? This will forcefully compress the lung. And this compressed lung even will be pushed to the opposite side. And that may compress the mediastinum and lead to mediastinal shift to opposite side. And even opposite lung may be also partially collapsed. So very dangerous, life-threatening situation. Right? Because it can lead to two problems. Collapse of the respiratory system and collapse of the vascular system, cardiovascular system. Cardio-respiratory collapse will occur. Why? Because when there's too much pressure on the lungs, can it do its ventilatory functions? No. Even other lung may be partly compressed also. So first of all, what will happen? That ventilatory failure leads to severe hypoxemia. It will lead to severe hypoxemia. Second problem will occur that when mediastinal shifting is occurring, there is kinking. Kinking means bend. Kinking and compression of mediastinal structure, especially cable system. If it is compressed and bent, can venous return come here? No. So what will happen? That venous return to the heart dramatically decreases. Right? And naturally, if there is no blood coming to the heart, what will happen to cardiac output? Decrease. So what happens? Cardiovascular system collapses. Right? And of course, when mediastinal shift is there, even trachea is also shifted. You are understanding it? Now in this person, The immediate step should be, the moment you suspect your patient is having dyspnea probably due to pneumothorax. What kind of pneumothorax? Tension pneumothorax. You should immediately do the decompression. Now, question is that in such patients we don't have time for investigation, and we have to diagnose the patient clinically. Now, how we diagnose it clinically? I will tell you about the clinical features. And first of all, before that, let few causes again. Remember, any type of pneumothorax can convert into tension pneumothorax. It means tension pneumothorax is really a complication of pneumothorax. It's a really very dangerous complication of pneumothorax, because pneumothorax is simply air or gas in the pleural cavity. But if this air or gas become under high pressure, then it is tension pneumothorax. So, how would you diagnose this patient? Let's do methodically, step by step. Right? Before I go for clinical feature, again, a brief review. Once the air escape and entry point closes, what is this kind of pneumothorax? Closed pneumothorax. Entry point during inspiration and expiration in both part of the respiratory cycle remains open. What is this kind of pneumothorax? Open pneumothorax. And if entry point allows the air to enter with every inspiration but doesn't allow the air to escape out during expiration, what is this kind of pneumothorax? Tension pneumothorax. Any kind of pneumothorax can convert into tension type of pneumothorax, but especially you should think of some causes, especially in your mind, CPR. Sometimes end up into tension pneumothorax. Positive pressure, mechanical ventilation. Positive pressure, mechanical ventilation. Then trauma, chest trauma, and then any other cause, but at least these three should be in your mind. That is, suddenly patient develops severe dyspnea and other features of tension pneumothorax, and patient is on, what is this? Positive pressure ventilation, or you were doing CPR and still patient is not getting better, right? Or there has been history of trauma, and after that trauma may be non-iatrogenic or iatrogenic. So, and after that patient developed the classical features of tension pneumothorax, immediate intervention, right? It's medical emergency. Now, what are the clinical features? Listen. This patient is undergoing a major problem, right? Breathing is difficult, severe problem in breathing. With that, in severe cases, there is also cardiovascular system is collapsing. Is that right? So when you look at the patient looks very distressed, anxious. In very advanced cases, maybe even cyanotic. And sympathetic overflow, diaphoresis, sweating. You see a patient which is having tachypnea. Rather, I must use the word patient under respiratory distress, because you will find that patient is fighting for the breathing with the help of accessory muscles of respiration. Patient is activating all his accessory muscles of respiration, right? So patient is under, when you look at the patient looks under respiratory distress, anxious, initially pale due to sympathetic overflow, and then in advanced cases eventually cyanotic, severe hypoxemia, and with that sweating, diaphoresis, right? You immediately check the vitals, pulse. It will be weak or strong?
Weak.
It will be weak. Cardiac output is dropping, but rapid pulse, right? Weak, rapid, weak, thready, rapid and weak, thready pulse. You check the blood pressure, it is progressively falling. Is that right? Then you look on the neck. Neck veins will be distended. Gorgeous? Engorgement. Oh my God. Sure. I thought he is saying neck veins will be gorgeous. No. They will be engorged. Right? Don't see these things in this situation. Save the patient first. Okay? So, again, patient under high stress, rather respiratory distress, pale, cyanotic, sweating, it means there is something seriously wrong. Right? It may be some cardiorespiratory issue. Pulse is going up and blood pressure is going down. Is that right? Respiratory rate is high. We say tachypnea. But then we come to those, you have to examine the chest to make more clear diagnosis. Now what you will find on the chest? First of all, that side, for example, I'm the patient with tension pneumothorax, and let's suppose tension pneumothorax is on the right side of the cavity, right? Pleural cavity. Now what will happen? Not only lung will go in, even chest wall will bulge out. Is that right? So chest wall will bulge out, and movement of the chest wall on the affected side will be less, reduced. So it means hemithorax will be bulging out, and movement of the chest wall will be reduced from the affected side. If you palpate the trachea, what will happen to trachea? It may be deviated to other side. It may be deviated to the opposite side of the pneumothorax. And after that, if you do percussion, this area where there is a lot of air, this will be hyper-resonant. It will be hyper-resonant. Even this air trapping area may enlarge so much that area of cardiac dullness is pushed on the other side, and in right sided tension pneumothorax, even diaphragm and liver are pushed down. Right? But up to now, what were the most important sign here? Deviation of the trachea. Deviation of the trachea, shift, mediastinal shift, which can be, so patient dyspneic, under distress, right? Pulse going up but weak, blood pressure going down. Immediately check, first of all, what is this? Trachea, is it central or not? If it is deviated on the other side, immediately do what? Percussion. That side will be hyper-resonant. If it is hyper-resonant, what is the next step immediately? Put your stethoscope. Absent breath sounds here. Absent breath sounds here. Now you are really making clinical diagnosis. That on one side of the chest wall is bulging, chest wall movement are less, trachea is shifted to the opposite side, chest wall is bulging, movement of chest wall on the affected side is less, trachea is deviated on the other side, neck veins are gorgeous again, engorged, because veins cannot drain into cable system. Engorged. Is that right?
No, that's not.
Immediately you percuss, hyper-resonant note, right? You auscultate. On the affected side, absent breath sounds. Forget about everything. Immediately go for wide bore needle. Right? Wide bore needle and second intercostal space, mid-clavicular line on the affected side. Push the needle in. If your diagnosis was right, clinical diagnosis was right, the moment you push the needle in, air will be come out hissing under pressure. Diagnosis is confirmed. Then what you do with the needle? Once you get the air out, you immediately
Remove it.
not remove it. Not immediately remove it. Keep the needle there. Right? In most of the cases, until you are not sure of the underlying cause of what caused this medical emergency, you stick the needle there and don't remove it. Actually, what you have done, you have converted the tension pneumothorax into open pneumothorax. You have converted the tension pneumothorax into open pneumothorax. Then, you can take a sigh of relief, and your patient may be breathing also well. And then you arrange for thoracostomy tube, chest tube, right? You need to put a chest tube so that if air, even if again traps, there is a way to get it out. You put a chest tube, and after that you remove the needle. After that you remove the needle. So it's very important that in case of tension pneumothorax, you should be under tension. You don't have time for investigations. First save the patient, then think of investigations and what really happened to the patient. Simple. Distressed patient, sweating, right? Tachycardia, tachypnea, hypotension, engorged veins, deviated Trachea, affected side hyperresonant and absent breath sounds. Rush for wide bore needle and stick it into second intercostal space, mid-clavicle line on the affected side. So decompress. So lungs re-expand. Is that right? After that, of course, you can, if you want, you can do all the investigations you like. You can do the chest X-ray, you can do ultrasound, even for underlying causes, especially when there is a secondary cavitary lesion. You would love to do CT scan. Is that right? Further investigations in detail will depend on what is the underlying what might be the underlying cause. Is that right? Any question up to this? Anything you would love to discuss? Yes.
What is the role of oxygen?
Yes, what is the role of oxygen? Again, this person is also put on high level of high concentration oxygen. I mentioned it previously. In any kind of pneumothorax, when you put high flow oxygen, that helps for the air in the pleural cavity, it helps it to increase its oxygen concentration, right? So that it can be better absorbed, right, than the nitrogen containing air. Is that right? Any more questions you have? Yes.
Sir, while doing CPR, if there is tension pneumothorax, patient is already unconscious, he may be dyspneic. So how we will come to know that there is tension pneumothorax?
Yeah, during CPR. It is not necessary that during the CPR you know that there is pneumothorax. If patient revives and then you find still there is difficulty in breathing, immediately put your stethoscope, check the trachea. And if you suspect it, forget about CPR, first put the needle. Right? Yes, you have a question.
In open pneumothorax, the pulmonary cavity is communicating with the outside.
Okay. Open pneumothorax, pulmonary cavity, pleural cavity may be communicating through the parietal pleura outside, or in other patients it may be communicating with pulmonary airways through the visceral pleura. Remember, any kind of pneumothorax, either it is having due to puncture of parietal pleura or puncture of visceral pleura. For example, tension pneumothorax, if it develops from the trauma, for example, stab wound, then of course air from outside is going in. But if tension pneumothorax occur after some cavitary lesion, as I explained in previous video, cavitary lesion melts away, a bronchopulmonary fistula form, right, and flap is there, and air enters into pleural cavity and cannot go back. In that case, air is coming from the lungs. So some patients of tension pneumothorax are getting the air through the chest wall, and other patients of tension pneumothorax might be getting air from the puncture of lung. The real mechanism is that trauma can lead to closed pneumothorax. For example, simple stab wound can lead to closed pneumothorax, can lead to open pneumothorax, even can lead to tension pneumothorax. Is that right? If there's stab wound and air is sucked in during inspiration, after that wound closes immediately and air cannot escape out, it's closed. Closed pneumothorax. If after the injury, if this big area is injured in the chest wall and air is during inspiration, expiration, it is able to move as it wants, inspiration in and expiration out, then it is open pneumothorax. But if oblique wound is there and flap is in such a way, during inspiration air goes and during expiration it cannot out, this will be tension pneumothorax.
In transbronchial biopsy, tension pneumothorax can occur?
Yes, in transbronchial biopsy, tension pneumothorax can occur, but more commonly other types of pneumothorax. Remember, any kind of pneumothorax can convert into tension, but probabilities are different. For example, if bleb rupture, chances of tension pneumothorax are extremely low, right? But if there is, let's suppose, positive pressure ventilation and patient develop pneumothorax, chances are that it may be tension pneumothorax. You need to act fast, right? So these are the basic concepts about the pathophysiology related with the pneumothorax. Class dismissed. Thank you.